Awesome. Thank you.
Okay, good evening, colleagues. Welcome to today's webinar. In the talk for today, we are to focus on the impact of non-pregnancy related infections on maternal death. We are not really going to go into the details of each and every disease, but rather to see what is the main problem and perhaps get a way on how to go about it to reduce these non-pregnancy related infections contributing to the maternal deaths. So I have nothing to declare regarding this talk. And as a content, we are going to look at the introduction and we just look at the scope of the problem in terms of non-pregnancy related infections. And then we look at the maternal deaths, global trend, looking at the Savings Mothers Report, the last one that we have from 2017 to 2019. And then specifically also dissect further into the non-pregnancy related infections and the HIV and obstetric complications. And then we also a little bit talk on the new kid on the block, COVID-19, and then we conclude. So as an introduction, we are very much aware that reducing maternal mortality is one of the key targets for the Millennium Development Goals, and this goal is Millennium Development Goal number 5. And the aim is to reduce the maternal mortality rate by at least 70%. Therefore, countries need an accurate picture of the levels and the causes of the maternal deaths. And globally, there has been a decline in the maternal death pregnancy-related infections. However, up to now, 90% of all the HIV-related maternal deaths occurs in sub-Saharan Africa, where we found ourselves. So if we are to look at the scope of the problem, there's many factors that contribute to why we're still experiencing quite a significant high of maternal deaths in sub-Saharan Africa, and more specifically related to the non-pregnancy related infections. And some of them ranges from local policies, cultural norms and socioeconomic factors that plays a role in a woman's inability to access care and receive appropriate treatment during pregnancy, childbirth, and postpartum. If you are to look at South Africa, it's one of the countries in the sub-Saharan part of Africa with the highest HIV prevalence. This is, however, despite having a very good and a large ART program, the HIV-related maternal deaths remain significantly high in South Africa. If we are to look at the South African maternal mortality ratio, it lies at 137 per 100,000, and this is according to the last triennium report of 2017 to 2019. But if we are to look at the Millennium Development Goal 5, we target that we want to achieve at least 70 deaths per 100,000. Clearly, you can see that we are still at almost nearly 2 times of what is desired. So there's still a lot of work that needs to be done to achieve this 70 deaths per 100,000. And also one of the new problems or the challenges that we are facing globally is the COVID-19 pandemic. And by now we are very much all aware that although pregnant women are not necessarily at risk of contracting COVID-19 compared to the rest of the general public, it appears that once they contract the disease, they are at risk of severe COVID-19. So if we are to look at the global trend and maternal deaths, and if we are to focus on the left lower hand corner there is a chart or a guide related to the maternal mortality ratio. And as the color gets darker, it highlights that the maternal mortality ratio is high. And if we are to look clearly, you can all appreciate that the burden of the disease in terms of where the most birthing mothers are dying is clearly occurring in the sub-Saharan Africa. And this is why we really need to do a lot of work in order to achieve the lower maternal mortality ratio. There's still a long way to go. And if we are to look at the global trend on what are the causes why mothers die in relation to giving birth, the leading cause globally, it is obstetric hemorrhage, and that is followed by all the other causes such as indirect causes, hypertensive disorders, sepsis, and other direct causes only contribute to 9.6%. Interestingly, as you can see there, the second from the bottom, HIV only contributes 5.5% of all the maternal deaths that are occurring globally. And as we'll see further, interestingly, almost all of these HIV-related maternal deaths occurs in this part of the world. This is just an extraction from the Savings Mothers report, the Triennium report of 2017 to 2019. And it clearly shows that the leading cause of maternal deaths in South Africa, it is still non-pregnancy related sepsis. This has not changed for many years. And the aim is that we want to have this change, at least in the next, the Triennium report that we are expected to have at the end of this year, and perhaps in the future Triennium report. So it just highlights the scope of the problem, or the major problem that we are facing in relation to the non-pregnancy related sepsis. And this contributed nearly a third, which was 23% of all the mothers that demised during that period from 2017 to 2019. The other causes includes obviously hypertensive disorders, and pregnancy still remains one of the biggest challenges that we are battling with this part of the world, followed by obstetric hemorrhage. As you can see, interestingly, if you are to look at the global trend, obstetric hemorrhage is #1, but here in South Africa, it's only #3. It highlights the difference in challenges that we are facing, and we have to approach this challenge differently compared to the rest of the world. And then other complications include medical and surgical conditions. And then lastly, the top 5 was the number 5 was the complications related to early pregnancy, more especially ectopic pregnancies and miscarriages. Contrary to that, if we are to look at the data from the UK, this is a maternal mortality rate report for the year 2020 in the UK. And as you can see there in the UK, that year, the maternal mortality ratio was 8 to 9 per 100,000, contrary to South African data, which stands at 137. Clearly, you can see that we have a very, very long way to go before we can achieve these numbers of 8 to 10 per 100,000 deaths. And interestingly, why are the women dying in related to complications of pregnancy? Clearly, non-pregnancy related infections does not feature on this picture. I hope you'll be able to see, and you can see that the top causes of why women die in the UK as a result of complications related to pregnancy is in fact maternal conditions, specifically cardiac diseases. And this is followed by other medical conditions such as epilepsy, stroke, and blood loss, which, as we mentioned, obstetric hemorrhage comes at #2 there at 15%. So clearly you can see, and the picture is pretty much different compared to what we are experiencing in this part of the world in comparison to the developed countries. This data is also, chart is extracted from the Triennium report of the 2017-2019, and it just shows us the causes of maternal mortality over the period of 5 years. As you can see there, interestingly, you can clearly, if you are focusing on the non-pregnancy related infections, there is no doubt that over the years, we have been making some significant positive notes in terms of reducing the number of women that are dying as a result of non-pregnancy related infections. And this is very much to the introduction of the antiretroviral drugs. And you can see that from 2011 to 2016, there has been nearly a 50% reduction in the number of women that died during that period. And as you can see, the trend continued to go down. However, as you can see, the trend still shows that it is still the leading cause of maternal mortality rate, and with more still needs to be done, because most of these deaths are actually preventable maternal deaths if we can really reinforce and impact and really strengthen our policies. Looking further on the non-pregnancy related infections in the further analysis of the 2017 to 2018 Triennium report. Interestingly, of all the mothers that died as a consequence of non-pregnancy related infections, 88%, nearly 90% of all those patients were HIV positive. This just highlights the significant contribution of HIV to the proportion of the patients that are demising as a result of these non-pregnancy related infections. And if we are to look at the overall contribution of these patients that were HIV positive that demise, this was nearly half of the patients at 43.4. Once again, it just highlights regarding, despite the efforts that have been made in terms of reducing the number of women that are dying, the numbers still remains quite very high. And the leading cause of why women were dying among those patients that were HIV positive, it was respiratory tract complications, specifically TB, PCP pneumonia, and other types of bacterial and viral pneumonias. And these were responsible for around 62.1% of all the deaths. And the other ones were immune system failure and septic shock, which stood at 20%. And once again, it still highlights that the issue here, it has to do with infection, which is most likely related to the impaired immune dysfunction associated with HIV. So furthermore, this analysis of the non-pregnancy related infections looking at possible avoidable factors, it was noted that in 82% of all the mothers that demise as a result of the HIV related complications, they were mostly patient-oriented problems. In other words, there have been some few avoidable factors, but 82 of these cases were related to patient factors. And this ranged from delay in seeking help, which was the majority at 63%, followed by those patients that never booked at all, and that stood at 36.6%. And there was also a number of patients that either declined medical or surgical intervention or advice that accounted for nearly a third at 28%. Interestingly, during that time, it was also noted that the number of the women that demise as a result of HIV-related complications, there were also avoidable factors related to healthcare workers, such as inappropriately trained staff, both in terms of both nurses and doctors, which was about 60%, which is quite a significant, quite a very, very big number. And perhaps this is one of the purpose of this talk, so that we can see how we can do something to reduce this number, because this mainly much concerns us. And looking at the interestingly also, it happened that majority of the deaths happened during the postpartum period or early pregnancy. So it highlights again that either when the patients are discharged, we do not give them either clear, good follow-up plans on how to manage the disease further. And the complications early in pregnancy are mostly related to the point that perhaps most of the mothers that are conceiving, they are conceiving without knowing their HIV status, or conceiving with their HIV positive and the disease is not optimally controlled. Perhaps they will come in with early pregnancy complications, but we'll look into that in a few slides. Okay, if we are to look at the basic effect of pregnancy on HIV infection, it appears that we are very much aware of the normal physiological changes of pregnancy, whereby the immune function is suppressed in terms of both the immunoglobulin and the cell-mediated immunity. And therefore, perhaps because of this suppression, there is definitely if there's already immune suppression related to HIV, it predisposes these patients to the risk of further acquiring the opportunistic infections. And most likely that's why it puts them at risk. However, on the further assessment on whether there is an effect on HIV, whether the pregnancy affects the progression of HIV, there is conflicting data. And one of the findings was whether, for example, it has been noted that the CD4 count appears to drop during pregnancy, but it has been some colleagues have argued that it might be mainly related to the normal physiological changes of pregnancy, specifically with the hemodilution effect. So there is no really concrete data which really confirms that pregnancy is associated with the progression of the disease. If we are, on the other hand, if we are to look at the effect of HIV infection on pregnancy, there is no doubt that HIV significantly affects the pregnancy outcome, and one of the most outcomes that we see quite very bad is the risk of mother-to-child transmission. And we know very much that with the introduction of antiretroviral drugs, we are seeing less and less of these cases. However, there has been some studies that have looked significantly at the impact of this disease on pregnancy, and some study by Scherer et al. Actually found that there is about a 3-fold increase in the risk of getting a spontaneous miscarriage in a woman with HIV. And this could perhaps be related to the other issues such as at risk of infection, and mainly maybe which may predispose these patients to having miscarriages. Other effects that has been associated with HIV is a risk of syphilis, and it has been found mostly in those patients that have HIV. Similarly, we are very much aware of the increased risk of opportunistic infections. I previously spoke about the risk of reduced impaired immune function associated with the normal physiology of pregnancy, which may be further be compounded by the effects of HIV. A study by Gray et al. There appears to be a risk of preterm labor, PPROM, chorioamnionitis, and stillbirths that may be associated with HIV when they are compared to the women that are HIV negative. And another study also found that there appears to be an increased risk of stillbirths compared to the patients that are non-negative. So if we are to look at the relationship between HIV and obstetric complications, related to obstetric hemorrhage, the data is inconsistent, and there is no concrete data which proves that HIV is associated with obstetric hemorrhage. And the definition of PPH mainly was not the same, especially those ones that were used in these studies. However, what has been found is that most women that are HIV positive are most likely to receive blood and blood products compared to the non-negative women. And this perhaps could be related to the anemia of chronic diseases, which is associated with HIV infection. There has also been issues whether there is any effect of drugs such as impairing the normal function of the body, especially with the coagulation. However, there is still inconcrete data which is really for confirmatory of these findings. And so if we are to look at the impact of impact on maternal deaths in the era of antiretroviral drugs therapy, there is no doubt that there is survival benefits of antiretroviral therapy, even without an advancement in the immune suppression. In other words, if the patient is started on antiretroviral therapy, regardless of whether they are fully immunosuppressed, there is definitely benefits in improving the pregnancy outcome. And there is also, we are very much aware of the suggestion of the decline in the maternal mortality associated with the option B plus regimen, which means that patients are started on antiretroviral therapy regardless of their CD4 count. I'm sure we are very much aware of where we came from, where we used to use cut-off HIVs on which patients to start on antiretroviral drugs, and on which patients we are to defer and start at a later stage when the CD4 count is significantly reduced. So we move on from that era, and now we are focusing on the option B plus, which is mainly that as long as the patient is positive, we want to initiate therapy as soon as possible. And we are very much aware of the the initiation of ART has significantly resulted in about 50% decline in the odds of a maternal death from TB. And this has been seen very much as the expansion of the ART program. And as you have highlighted earlier, TB is one of the leading opportunistic infections that causes during pregnancy. So if we are to look at some success on the PMTC or the initiation of antiretroviral therapy in terms of pregnancy outcome, we are on a positive note. On this side of the world, Botswana is one of the countries that was to be given an award at being to reach a key milestone in eliminating the mother-to-child transmission. And the success to this award was mainly made possible by, this is one of the countries that initiated this option D+ that I just spoke about. And it was also the first country in Africa to adopt the dolutegravir regimen, which is now the first line, considered to be the first line globally in terms of managing HIV infections. And furthermore, if we are to look at this data, it speaks about the impact of HIV in the initiation of antiretroviral therapy in sub-Saharan Africa. Interestingly, as you can see, and I want to focus on this second bar, as you can see, sub-Saharan Africa, the antiretroviral coverage is about 95%, meaning 95% of those patients that tested positive appears that they are initiated on the antiretroviral therapy. Perhaps the challenge is that are we really achieving the fully viral suppression and the immune competence that we need for these patients, or we need to go back and understand why is, despite having a 95% antiretroviral therapy, the maternal mortality rate related to HIV remains quite significantly high. And this is one of the study that looked at the trends of the maternal deaths related to HIV infections on the background of changing HIV management guidelines. And this was a 19 years follow-up study at a big institution associated with Wits University. And I think it included Joburg Gen and Charlotte Matrege. And interestingly, what they found is that, yes, there has been some significant achievement that has been made in terms of decreasing the institutional maternal mortality rate related to HIV. However, it remains unacceptably high. And we now need to look at the efforts of the drivers on why this mortality remains to be high. And we need to assess the impact or the success of the antiretroviral therapy so that we can come up with better remedies to resolve the situation. Again, this is another study from Joburg. It also looked at the causes of maternal death. And once again, it's still coming out that the majority of the deaths at this hospital, which is Natal Spirit Hospital, to HIV. This study comes from Mpumalanga, and it looked at the patterns of engagement of HIV care and in pregnancy and breastfeeding women. And the findings are similar. And they found that almost half of all the pregnant women were not really having optimal ART coverage during the MTC2 risk period. And they also called for programs that need to focus on the improvement of and improving the retention, and also the leveraging the new pregnancy and the re-engage the HIV positive women on heart. So it appears that the problem has to do with what we are doing with those patients that are initiated on ARV. It appears that we are not really achieving fully viral suppression. And it appears that this significantly contributes to the risk of new infections and subsequently contributes to the risk of more women dying from HIV. Another study also looked at one of the impacts, what could be one of the impacts contributing to why the HIV infections or maternal mortality rate remains high despite having an effective antiretroviral program in place. And this study looked at whether the movement of a woman from, for example, from one province to another have an impact on the women continuing with the antiretroviral therapy. And interestingly, in this study, they also found that most pregnant women move around within the country at the time of delivery. And they also found that because of this, they appear to default their treatment. And as a result, it significantly contribute to the higher risk of mortality. And this is despite the scale up of this universal ART. We are very much aware that this significantly contributes to this number maternal mortality. So what do we need to do in order to improve the situation? We are very much aware that we are diagnosing enough women that are positive, but are we really managing them very well as we should be? And we need to familiarize ourselves with these two key recommendations. One is the WHO recommendation on the antenatal care for a positive pregnancy experience, which was released early in 2018. This is followed up based on the WHO recommendations. The South African National Department of Health also released the guidelines on the prevention of mother-to-child transmission, and subsequently also preventing the maternal mortality rate. So the focus on these guidelines are pretty much the same. And the focus is that the guideline outlines, at least the South African guidelines specifically outlines by which to achieve the targets of zero HIV transmission and also an HIV-free generations. And these four pillars that the government recommends and that we should be adhering to in order to reduce the number of women that are dying because of HIV-related infections. The first pillar deals with the primary prevention of HIV. And this goes back to the basics of prevention of ABC, being abstinence, be faithful, using of condoms to prevent transmission, and also early detection or diagnosis and initiation. D also involved including drugs. So basically, this is what the first pillar is talking about. It looks at those also including mainly to reduce the risk of transmission. So it goes back to those patients that are at high risk of acquiring HIV. We are very much aware now that PrEP is widely available, and we must also make this information very much accessible so that we can prevent new transmission. So the first pillar simply deals with prevention of new transmission. So perhaps we really need to do more and go back to the basics, make the women aware that pregnancy is HIV is associated with risk of pregnancy. If you are to look at the nowadays of COVID, most women are very much aware that if you have COVID and you are pregnant, it appears to be associated with poor outcome. But I'm not sure if that is the same, whether most women are aware that equally so, if you are HIV positive and you are not on treatment or not optimally treated, the risk is pretty much the same that is associated with a poor outcome. The second pillar deals with the prevention of unintended pregnancy among the women of the reproductive age that are dealing with living with HIV/AIDS. And this is where the role of contraception comes in. And here we are talking about long-acting reversible contraception, and so that we make sure that no woman falls pregnant when the HIV is not controlled. The approach should be similar to other chronic conditions such as diabetes. We always want pregnant women that are diabetic to fall pregnant when the disease is optimally controlled. So the approach should be the same. Patients should first be controlled on treatment, and if they are not controlled, they should not be falling pregnant. And perhaps the right people that we need to start talking about integrated clinics, especially with the internal medicine, as most of these women are managed by the physicians. And so perhaps we really need to start up integrated clinics, whereby once the patients are started on antiretroviral therapy, the next question should also be to discuss whether they are planning to fall pregnant. But if they are not optimally controlled, it should be advised against pregnancy until the disease is under control. And the third pillar deals now with prevention of the transmission of a woman who is positive to her infant. And this deals once again, with monitoring or the surveillance to make sure that these patients the disease is optimally controlled, they are virally suppressed, and they are immunocompetent, and their CD4 count is quite high. And we also recognize those patients that need treatment for prevention of opportunistic infections such as TB, cryptococcal meningitis, and start them on those treatments. And then the last pillar provides with deals with the providing of an appropriate treatment, care, and support to the women that are living with HIV and the children and their partners and the family. And perhaps this is usually we see this, if you are to recall one of the slides I highlighted earlier, that most of the patients actually demised during the postpartum period. So it means that most of the time the patients comes, they deliver, we discharge them, and it appears that we do not really formulate a clear follow-up plan for these patients. And this is what we need to deal with this in the fourth pillar. Equally so, the guideline also outlines the 4 pillars that we need that are needed to achieve also 0 TB infections, as I highlighted, and we mentioned earlier that TB is the leading cause of opportunistic infection in the women of that are HIV positive. And the primary prevention, again, pillar 1 deals with primary prevention of TB, similar to HIV. So we need to prevent new infections of HIV. And for those patients that are falling pregnant again, and we need to also prevent those unintended pregnancies among those patients that are on treatment. So the aim should be for those ones that are on treatment, the next discussion, if you have a TB positive woman of a reproductive age, they should be counseled on a long-acting reversible contraception and be advised to defer pregnancy until they have completed their treatment, because we are very much aware that it appears there to be an association between TB and pregnancy and poor outcome. And the third pillar deals with prevention of TB transmission to the infant, and mainly this deals with postpartum in terms of breastfeeding and all that. And the last pillar deals with providing appropriate treatment care support to the women living with TB. And one of the key aspects that came out of these guidelines, especially with regarding to HIV, is that the recommendations is that for the HIV negative to focus on early detection and diagnosis, is that instead of only testing a patient once during the antenatal period, they should be counseled for voluntary testing for HIV at each and every visit. And similarly, so for these patients should also be counseled, and they should be screened for the signs of TB at each and every visit. As we are very much aware of the new Bank Plus contacts of 8 visits, we should be screening for all these conditions at each and every visit. And for those patients that are at risk, especially the HIV positive, if they have a CD4 count that is less than 350, they should be started or counseled on the INH therapy or the TB preventive therapy, isoniazid. And it's also advised that for those ones that have a CD4 count that is still more than 350, they can defer TB preventive therapy until after delivery. But as soon as they have delivered, they should be started on TB preventive therapy. So the aim is to reduce and decrease the number of the patients that are demising. So I'm urging each and every one of you to just familiarize yourself with this document. It's quite a very good and detailed document. So if we are to look now on the, move on to the new kid on the block, which is COVID-19, we are very much aware of the impact of COVID-19, which is way, way beyond anyone's expectations. So if we are just to look at this slide, just shows the impact of COVID-19 on pregnancy and maternal deaths in 2020 compared to 2019. So what I'm trying to highlight here is that if you can just see here, this slide, you can clearly see that these are the total number of maternal deaths in 2019. And then compared between January and March, and this is also the same number of maternal deaths between January and March in 2020. You can clearly see that there was a significant reduction of about 35 women, which was about a 13% reduction in the number of women that demised just before April. And if we are to look on April 2020, here, if we are to focus on here, April 2020, we know that I think South Africa went into lockdown towards the end of March, and that coincided with the peak of the COVID first wave, which was around May, June in 2020. So what happens during that period of April to September, you can clearly see that there has been a 50% increase in the number of women that died during that period, which coincided with the peak of the first wave of the COVID. Again, this graph just shows the similar findings that we spoke about. As you can clearly see that before maternal mortality rates, and immediately after lockdown, which coincided with the peak of the first wave of the COVID-19, and you can clearly see that there has been a peak and an increase in the number of maternal mortality. So clearly the findings of these results no doubt shows us that there has definitely been an impact of COVID-19 on the number of women that demised during that period. Once again, this data also came from, it's a cohort study that is a multi-centered study that was done at around 36 hospitals across South Africa. And this data looked at 673 infected and hospitalized pregnant women. 217, which was 32% of them, were admitted with COVID-related illnesses, and 456 were admitted with other indications. And of note, during that period of the study, there were 39 deaths, and 32 of these 39 deaths were among the 217 group which were admitted with complications related to COVID-19. And this is compared to the 7 maternal deaths out of the 456 that were admitted with other indications. And interestingly, they also found that among the women that demised, there was also an issue of that there was a number of women that had maternal TB, but they did not really find any association between HIV and the risk of COVID-19 or COVID-19 during that period. So their conclusion was that the maternal mortality rate was high among the women that were admitted with COVID-19 infections compared to those women that were admitted for other indications. And they also found that there appears to be an association between TB, but not with HIV. Once again, this data just shows significantly that COVID-19 significantly increased the number of maternal deaths during this period. Again, if we are to look now on the positive note, more data is coming out to prove the safety and the effectiveness of the COVID-19 vaccine in both pregnant and lactating mothers and non-pregnant women. And this meta-analysis and systematic review included 23 studies that I studied the effectiveness and the safety of Pfizer, Moderna, and the J&J and the AstraZeneca vaccines. And they concluded that COVID-19 vaccination in pregnant and lactating individuals was immunogenic. In other words, the women that are vaccinated while pregnant, they were able to mount an immunogenic response with any adverse outcome, be it obstetric or neonatal complications. So they found that vaccination during pregnancy is safe and effective. Similar, this is another meta-analysis that also looked at an effectiveness and the safety of COVID-19 vaccine among pregnant women. And we can clearly see, if we are to look on this two forest plot, the first one is focusing on the risk of getting a SARS-CoV-2 infection after being vaccinated. And if we are to look here clearly, these results just shows that being vaccinated reduces the risk of getting an infection by more than 50%. As you can see there, that the odds ratio was 0.49. Similarly, among the patients that were hospitalized, it shows that those patients that were vaccinated, being vaccinated reduces the risk of being hospitalized by again 50%. So this analysis just again confirms that COVID-19 vaccine is indeed effective and it's indeed safe, and it's highly recommended that policymakers should formulate targeted strategies to improve the vaccine coverage among pregnant women. If we are to look at this data again, it's also coming from Europe. It looked at on severe COVID-19, whether severe COVID-19 in pregnancy was almost exclusively limited to unvaccinated. So what they found is that, as you can see on this slide, so what they found here is that, as you can see, the relationship between being vaccinated and getting severe COVID-19. And clearly the first country that looked at is the UK. As you can see, they found that at that time they had 230 women that were admitted to critical care, and 98% of those women were unvaccinated, as you can see there. Similarly, in Netherlands, they had 52 patients that were admitted to critical care, and again, 90% of those women that were admitted were unvaccinated. And the picture is pretty much the same. In Norway, it's also the same. 100% of all those patients were unvaccinated. Finland was the same, and in Denmark. So this slide again once just strengthens the effectiveness and the safety of vaccine and prevention of severe COVID-19. So what do we need to do in order to prevent these maternal deaths related to COVID-19? Last month, the South African National Department of Health released these guidelines, which are focusing on how we should manage these patients to prevent maternal deaths related to COVID-19. And there's no doubt that vaccination against COVID-19 is the key into antenatal care services, although obviously should be on an opt-out basis. And preferably, we want these patients to be vaccinated before they fall pregnant. And also, we need to have accessible screening sites for COVID-19, and this includes having rapid antigen tests. And we need to identify those patients that have severe COVID-19 so that they should be transferred to the appropriate level of care on time so that they'll be able to improve their outcome. Once again, we still need to focus on the IPC prevention measures such as wearing masks, social distancing, and hand sanitizing. So other infections that have also contributed significantly to the maternal mortality, especially in this side of the world, we're very much aware of the malaria pandemic, endemic in this part of the region of the world, both in South Africa and also in Namibia. We experience a high number of maternal deaths related to pregnancy. So we just need to have a high index of suspicion, and we need to advise our pregnant mothers that are traveling to malaria endemic areas on prevention measures, and also to have a high index of suspicion if they come so that we diagnose them early and treat them early. Hepatitis in pregnancy is also a problem, specifically hepatitis B related to HIV, although we know that the antiretroviral drugs, if these patients are on treatment, we know they also cover treatment for hepatitis B and they prevent the progression of the disease. However, one of the diseases that we have seen also in this part of the world is hepatitis E, which is an orophycal disease, usually associated with people that live in the poor areas of the poor socioeconomic status. And in Namibia, 2017, there was a hepatitis E outbreak, which significantly contributed to the maternal mortality rate during that period. And it's just something that we need to be aware of. If a patient comes to us, we need to have a high index of suspicion for some of these conditions. Listeria monocytogenes, we've been very much aware of the outbreak during the 2017-2018, although not really having a significant impact on the maternal mortality compared to the perinatal outcome. Perhaps it's just something that we also need to be aware of, that it's also one of those infections that might contribute to the maternal mortality rate. Zika virus, we are very much aware of the impact, which outbreak in Brazil in 2015, although once again, the most effects was also on the perinatal outcome. The other viruses that are common, we are very much aware of the SARS and the MERS-CoV-2, and specifically these viruses compared to COVID-19, they were found to actually more severely contributed to the maternal mortality rate. So if we are to look now, what does the future hold, especially with regarding the HIV, we are very much aware that it is a battle that we are having this part of the world. This data came out as of March last month. There is many studies now that are looking at the mRNA vaccines related to HIV. And this is mainly with the background of the success of the mRNA vaccine based from the COVID-19. So perhaps we might be getting the mRNA vaccine for HIV in the future. And these studies are still at the phase 1 level. So it is just something that we need to be aware of, and perhaps we probably might get some vaccine in the future. And this is just perhaps something that in the future we might, considering the rate at which the SARS-CoV-19 mutates, COVID-19 vaccine perhaps might be something of a seasonal vaccine similar to the influenza vaccine, but obviously we are yet here, it's still early days, but it's just something that we need to be aware of. So in conclusion, HIV continues to be a challenge and a major contributor to maternal deaths. Prevention remains the major intervention against HIV, which should be viewed and managed as a chronic condition. And healthcare workers must familiarize themselves with policies and the guidelines in order to minimize the mortality and the morbidity rate from non-pregnancy related infections. And vaccination against COVID-19 prevents maternal deaths. These are some of the references that I use, and thank you very much.
Yes, Dr. Mvula, thank you very much for that. I don't know if Dr. Magagula was able to engage, but yeah, we really want to appreciate this informative session. It was and it is an encouraging, there are elements that are encouraging, Doc, though I think we will have a number of discussions around some of the critical gaps that you have raised. Dr. Magagula, are you able to hear me? Would you like to make any immediate comments before we take a few hands and questions? Colleagues, if you want to make your comments, you may raise your hand. I will
can I just mention something quickly?
Yes.
Yes, I think perhaps this discussion is a good build up to your talk that is due next week. I think it will probably give us even more better insight into really how should we really tackle and really manage these HIV positive patients so that we can reduce this maternal mortality rate. I think it's really a good build up to your talk.
No, thank you for that. That is quite coincidental, because when I do the HIV master classes, the audience has been saying, when are we talking about pregnant women, So for some reason, I didn't see the relationship until today when I was doing the slides. I was like, oh, okay.
Yes.
A great one. Yes. Thanks for that, Dr. Mvula. Dr. Magagula, in the meantime, and then before you say something, Dr. Billy, I saw that we have a PMTCT program manager here, Ms. Nomsas Tole. I saw also the Mother and Child Health Manager, Ms. Ansi. If after Billy, they would like to make some just comments around your presentation, because I think you raised a lot of public health issues, and then it would be great to hear what they think around HIV, COVID, and TB, this trio. Yeah, Dr. Magagula, thanks.
Thanks, Dr. Mawela. Thanks, David, for the awesome talk. I think you are really an awesome speaker as usual. So I'm not too surprised that your talk was, quite well researched, and lots of studies, lots of data that came out from there. This is a typical Mvula, I know. So thank you, Dr. Very informative.
Thanks.
It's very interesting. You mentioned. Awesome, man. You were mentioning Lisiho's talk soon coming. I probably not been reading much on HIV. I didn't know that already we have a poor virological suppression on dolutegravir. I was like, this one is going to be an interesting one. Yeah, so just a few, maybe one or two things for me. Just a reminder to colleagues, those who are still in the public sector, there's gatekeeping codes that are used, if we want to monitor the viral load during pregnancy. So if she's not delivered yet, we use that C# PMTCT, and a delivery, C# delivery. So always remember, otherwise our viral loads remain unknown, and some of the reasons could actually be due to gatekeeping issues. Just a practical one, Dr. Mvula. I had one visit last week to one of our referring institutions here in Nelspruit, and we're discussing the use of antibiotics around delivery. because we have a lot of sepsis, going on. It's either at vaginal delivery, they come back with endometritis or septic episiotomies, or at Caesar, they come with overwhelming sepsis, post the Caesar. Just a few pointers, perhaps as comments as to how we can reduce sepsis around delivery particularly.
Yeah, I see there's a building comment on that by Dr. Moloi as well. He's saying, thanks for an informative talk. Can we have a comment around wound sepsis and morbidity and mortality? So I think it's linked to what Dr. Magagula is raising. Thanks.
Yeah, I think, no, definitely, there is no doubt that it appears, and it's interesting when I was also preparing for this talk to find that what came out of the 2017-2019 Triennium report was actually that majority of the deaths occurred either early pregnancy or during the postpartum period. Clearly, it highlights something that we are not doing well in that aspect. And I tend to probably believe that, yes, it has to perhaps do with the issue of this risk of sepsis. But the question is that should we routinely prophylactically be giving antibiotics just because one is HIV positive, especially considering the effectiveness of the ARVs? If they are virally suppressed, I tend to differ and say perhaps I don't see if there's a role of giving routine prophylactic antibiotics. However, should there be any other risks, that predisposes the patient to having sepsis, such as perhaps episiotomy wounds? Those are some of this. I think we need to look at whether this patient will really be able to take care of these wounds when they are at home, or if so we need to individualize. I think we need to individualize the patients if they had prolonged ruptures of membranes or they had any other risk factors. And I think perhaps those are the patients that would benefit from prophylactic antibiotics. But it's definitely really something that, and perhaps what we also need to adopt is the issue of follow-up. Because what is coming out is perhaps that patients, we are not following up these patients. And I think we need to go back to the tradition. I know there used to be the 3 days visit. I'm not sure how many hospitals are really sticking to that routine 3 days and 7 days follow-up visits. I think perhaps that will also contribute, and it will allow us to catch these patients earlier enough while the disease process is not yet advanced. What is your view, Billy?
No, definitely, I fully agree. For cesarean sections or for patients who are going for Caesar, yes, there is that recommendation to use prophylactic antibiotics just before you start cutting. And we actually noted at that facility where we were visiting that they were actually using 1 gram, which is currently not the recommended dose. So I think the recommended dose actually be 2 grams, and for those class 3 obese women, it would actually be 3 grams. And for the NVDs, definitely there's really no role in it, as far as I can recall.
How quickly?
Except if there's other risk factors, of course. Even for the episiotomies, I know sometimes we just routinely give antibiotics, but it actually may not benefit the patient as such.
Yeah.
You're saying, Dave?
Yeah. No, thanks, guys. I see you miss each other very well, so let me crash in there. There's a number of questions around some of the opportunistic infections that contribute to maternal deaths. One was asking about what's your take on crypto screening. This is one particular infection that is very close to my heart, because we once reviewed the maternal death where the woman had booked early. She had a very low CD4 count. Crack antigen was done, but the results were not reviewed. She presented in the 3rd trimester with very bad meningitis, and she couldn't be saved. Only during the reviews, we picked up that the crack antigen, was positive very early in the 1st trimester, but with the system sort of, failed her. So I'm commenting on your behalf, but I don't know if you want to add to what I'm saying, to say there's also
Yeah,
some of
no.
these other infections as well. Yeah, yeah.
Interestingly, what they found also in the 2017-2019 Trinium report, they found that the number of women that demised because of crypto significantly went down. But what is still the new recommendation still calls that if a patient is having low CD4 count, specifically the cap is at 100, is that automatically you need to do cryptococcal antigen for those patients. But I still believe that the old tradition, what didn't really come out is the prophylaxis in the new guidelines. Whether we should, when do we start the patients on the prophylaxis? Because previously we used to start them if the CD4 count was not 200, if I'm mistaken. We start them on prophylaxis.
Yes, you mean which one? The Cotri?
Yes.
Yes, yes. The current guideline talks about the CD4 count of less than 200 cells for
Okay, good.
Yeah.
Yes. Yeah. All right, good.
Yeah.
So I think it's just something that we need to be aware of. Yeah.
Great stuff. So just a few things, though. Can you get into the details of what kills women when they are HIV positive? I haven't reviewed the data recently, but I know that there were a number of publications which actually showed that even if you control for everything else, if you disaggregate women by HIV status, women who might be having postpartum hemorrhage, we tend to see HIV positive women who have hemorrhage doing badly, you know. And there was a number of issues raised, but I want to hear your views around, you know, are HIV positive women treated the same way as HIV negative women when they present with your traditional obstetric complications, or what's your experience in that space?
That's a very good, interesting question. That's what I actually tried to highlight with one of the slides to really, to find out if there's really a link between obstetric complications and HIV. Interestingly, the only link that really came out was related to anemia. It appears that patients that are HIV positive, they usually have anemia compared to the general population. Perhaps, obviously, this we know that is related to the anemia of chronic disease. And once they are anemic, these are the patients that are prone to end up with a blood transfusion. But what we also know now with anemia is that it is a risk for, especially specifically for obstetric hemorrhage. It has been proven that patients that are anemic during the antenatal period are at risk of obstetric hemorrhage. But as to really why they die, it appears I'm not except the one of the opportunistic infections that we are very much aware that they are the most killers of the patients among this group, specifically TB and the PCP and other pneumonias. Regarding the pure obstetric complications, the other data that I was also looking, there was also some study that looked at whether they're at risk of hypertensive disorders in pregnancy, and it was also not really, there was not really such an association. But I must mention, yes, there is more studies that are looking into that, but there appears to be no really a specific complication that is purely that has been found to be associated with HIV, except the opportunistic disease that we spoke about.
Great stuff. I see your colleague appreciates your presence here, Dr. Mudau Ramwezi. I think you guys are the same. He says,
good, Mudau, thank you.
He says great talk from your side. Before we take the last few questions, let me just check before I take the managers, just to check with Ronia. Ronia Gerardo, would you like to make a comment? You may unmute your mic. Ronia Gerardo. You may, yes. Do you have a question?
Can you hear me? Yes.
Yes, we can hear you.
Thank you so much. Okay. Thank you so much, Dr. Mbula, for that brilliant talk. It's always nice to go back to things that we don't always pay attention to. I have one question and just a few, a comment with regards to the statistics, actually the national statistics. My concern is that when we say HIV-related maternal death, should it maybe not rather be maternal death in HIV-positive women? The reason I'm saying that is because if, for instance, you have a mother who's diabetic and she's poorly controlled, she might end up with a bad outcome and even maternal death. Same applies if you have a mother who is HIV positive that is poorly controlled or not on treatment with low CD4 count, high viral load, might also have a bad outcome. But then statistics gives us information that if a woman is on ARVs, then she will do well. Same apply to a mother who is diabetic, will also do well. So since we live in a continent whereby almost 2/3 of the population are HIV positive, if you have a mother who is HIV positive and diabetic, even if she's doing well on her HIV treatment, then if she dies, she makes it to the statistics of HIV-related maternal death, which for me sounds a bit maybe not fair. So if we know that most of our population, or 95% of them, are on ARVs, and statistics or studies are showing that they are doing well, my question then will be, how can we then assess HIV as an isolated cause of maternal death? Thank you.
Causality.
Yeah. No, thank you very much, Geraldo. That's she's my colleague. It's a very good point. Yes, and you are right. You are correct. I think that it's somehow a confounding factor if you put it in that way. Where do you draw the line? But I think the point is that perhaps, and I think it's probably something that I never thought about it, but I think perhaps in the future, because it appears that diagnosing is not a problem, diagnosing HIV, and putting the patient on treatment is also not a problem for us. So the challenge is that once the patients are on treatment, are we really doing enough to monitor that they are virally suppressed? And how many of those ones that really, I think we need to go into the details analysis and see how many of those patients that really demised as a part that were virally suppressed and how many were not virally suppressed. And I think it's something that we need to so that we can really understand where is the core of the problem. Because as it stands, yes, the numbers are still regrettably very, very high, despite having most patients on treatment. We still can't understand why are we still having more people that are demising. The other issue is perhaps reinfection as well in the community. And I think it's something that I think it's a challenge that we really need to do more to understand why are we still having more patients dying despite having a high antiretroviral coverage.
Thank you, Doc. Thank you, Doc. I see there's a hand by Abiodan Adewale. Abiodan, you may unmute your mic. Abiodan Adewale, you may unmute. All right. Oh, yes, we can hear you.
Yes, thank you. I just want to congratulate Dr. Mvula for the presentation. Actually, you have answered my question. My question was on the cryptococcal infection, because I've seen two in our practice here in Namibia. And that was why I was asking, and it seems you have provided answer from your own practice too. It seems the system still keeps failing some of the few women who incidentally have this cryptococcal infection, because both cases, they were managed as a case of meningitis / eclampsia in pregnancy. And unfortunately, the two demised. So I was just trying to ask him if during the search for literature, if there is a need to probably routinely screen, or if there is a medication that we can put to them, or if there is a high index of suspicion, that is able to come across in the literature, so that some of these morbidities or mortality that tend to follow such infection, we don't have them recurring in our practice. Thank you.
Yeah, I don't know, Doc, whether in Namibia you have the same protocol we have here, because in South Africa, all HIV positive pregnant women with CD4 counts at least below 100 cells must receive a serum blood crack antigen. And if that test is positive, the current protocol requires that they also get a lumbar puncture. But the lumbar puncture should not delay the initiation of a high dose fluconazole, 1,200 milligrams, for at least 2 weeks, and then we taper it, and then it must be continued for at least a year. And the scenario that I shared, the woman had a positive crack antigen. That means she had a disseminated crypto in her blood, but we did not intervene when we had a chance to do so. So I'm not sure, Dr. Mvula, what's your, in Namibia, you have the same protocol. I'm not sure about other regions in Africa as well. Yeah.
Yeah, thank you very much, Dr. Adewale. Thank you very much. Yeah, so yeah, it's pretty much similar, the same. Most of the recommendations that we follow is mainly adapted from the South African system. Yes, and that's very much true. I think Dr. Adewale just trying to highlight that the other issue that sometimes we tend to, you know, if a woman is fitting in pregnancy, we focus and just say it's a preeclampsia, and just highlights that there's also some few. We need to have a high index of suspicion. But it is really a challenge, and something that we really need to look at, and just have a high index of suspicion. But yes, in terms of the guidelines, it's pretty much the same. Yes.
Yeah, my colleagues, I know that we are behind time. Let's just take a few more questions for 5 minutes, and then we will wrap up. Dr. Mvula, if that is fine with you. Let me ask Makia Mashiane. Makia Matiane. Your hand is up. You may unmute. It seems like it's a sister. Sister Makia, are you able to unmute? All right. I don't think we are able to. Yeah, okay, let's do it this way. I'm going to ask Ms. Nomsasi Tole. She's the program lead for the PMTCT, Prevention of Mother-to-Child HIV Transmission. I'm going to ask her to make her comments. Ms. Nomsa, you may unmute. I see your hand is up. Yes. You can make general comments and any other additional key points you want to make. Thanks.
Okay, thank you very much, Dr. Mawela, for the opportunity, and thank you, Dr. Billy and Dr. Mvula, for the valuable information that you shared with us. My comment, I had, please pardon me, I was driving when the webinar started, but I managed to get that most mothers die due to HIV-related infections, and most of them are due to respiratory complications. What I want to echo to our colleagues is that there's an intervention that is not really well implemented, the gene expert, to all pregnant HIV positive mothers. Please, colleagues, let's do a gene expert to all HIV positive pregnant mothers. And those with a CD4 count of less than 350 during pregnancy, we need to initiate them on TPT. And they should be pregnant, yes, for TPT, initiated on TPT for 12 months. And those, we defer TPT on those with a CD4 count above 350. And the second comment is about the viral load monitoring. Many people are still confused as to what is the schedule for pregnant women and the general patients. Please look at your guidelines, colleagues. For pregnant women newly diagnosed with HIV, we do a viral load at 3 months of ART initiation. Most of the viral loads, you'll find that they are taken at the initiation of ART. Of course, it will be high, but we need to take the viral loads 3 months post-initiation. Mothers who fall pregnant while on ART, let's do their viral loads at booking. And lastly, Dr. Billy made this comment about the electronic gatekeeping codes that we need to put on the lab requisition forms. See hashtag PMTCT is for mothers during antenatal care. Mothers in labor and those who have delivered, it's C hashtag delivery. And again, with the delivered ones, if they were missed during labor or in the delivering facility, please, within the 6 weeks post-delivery, you can still do that viral load and report it as a delivery viral load. Thank you so much.
Thank you, Sister Dr. Mvula, you can hear that's from the program side and us trying to respond. Says Ansi, would you like to make any comments from a women's health point of view? Thanks.
Okay, good evening. Thank you, Dr. Mawela, for the opportunity. Thank you, Dr. Mvula and Dr. Makakula for the presentation. I am not going to add a lot, but I was very happy. The presentation was very integrative, especially that Doctor also spoke about the issue of COVID. I think we received that guideline, was it last week or 2 weeks ago? Yeah, COVID is doing a lot of problems for us. Since 2020, we have seen the increase of maternal deaths and also the issue of pregnancy-related sepsis. We're still seeing cases, especially on the last triennium, 2017 to 2019. It is still mentioned together with non-pregnancy related. So yeah, that's what I'm saying. The presentation was integrative, and I think it has assisted us. If we can all go back, look at the guidelines and try to implement them correctly. Thank you very much.
Thank you for that. I think, colleagues, because of time, we have neared the closing. What is important to note is that when we say non-pregnancy related infections, it's a very broad spectrum of infections that can actually, happen. Even rare things sometimes, do happen. But I think the foundation has been laid and we can just build on what we have shared today. Dr. Magagula, before I ask Dr. Mvula to do his closing remarks, as a Minister of Health in South Africa, advising us on the top 3 priority interventions, Dr. Mvula, prepare yourself. Dr. Magagula, may you say your closing remarks and really appreciate the presentation as well. If you are still there, thanks.
Thank you so much, David. I think it was really an informative and very interactive session. Unfortunately, we are really pressed for time, you see. But there's a lot of questions around PrEP. There's a lot of questions around COVID-19 and all that. So yeah, it just shows that we probably might need you very soon to come back and address some of these issues. It would be very awesome, and it's really good to hear that we've got colleagues out in Namibia that attended and have been interacting with us. So thank you so much, David. We appreciate the time, the effort, and all the knowledge that you have imparted to us over here. We really appreciate it. And I think for me, the take-home message is we still have a big issue with non-pregnancy related sepsis. There's a lot that still needs to be done with regards to programs and the actual work being done on the ground. So yeah, thank you so much, David. We appreciate you very much.
Thank you. David, the Minister of Health, your top 3 advice, and then you can also say your closing remarks. Thanks, Doc.
No, thank you very much, colleagues, Billy, Lesotho, for organizing this platform. I think it's really quite commendable. And nothing much, I would just like to say thank you very much. And really, the message is clear, like Billy mentioned, it is a non-pregnancy related infections is still a leading cause of maternal mortality. And it has been like that even before the initiation of ARVs in South Africa in 2004. But still, despite this having the biggest antiretroviral program. So the challenge is for us now to see how we can really mitigate this and really reduce the number of these patients that are demising. And I think we really I think we are sleeping a little bit on the prevention issue, and I think most people are not really aware. And I think we need to do more health awareness, promote still the basic ABCs of the early 90s when HIV was still a big problem. I think it might not be a problem in the general public population, but in pregnancy, clearly data is showing that it is a problem. And I think it's mostly because most patients are falling pregnant while they don't know their HIV status. By the time they come to the system, they usually come with a very weak immune system and a very high viral load, and they're compounded by the physiological immune suppression of pregnancy. They just end up with opportunistic infections, and that's the end. So I think we can do more. Thank you, colleagues.